Hi everyone, it's so great to be with you today. It's always such a privilege to come in and share my experiences that I'm very lucky to have with you. So I was the Health Promotion Coordinator for Afghanistan, which is quite a unique position. It's an intersectional position where we're supporting all the various different projects in Afghanistan with health promotion support. So in Afghanistan, we have Afghan health promotion managers, which is really, really fantastic. And I was just supporting them through coaching and training and generally supporting the teams with strategies and new approaches and so forth. So it was really fantastic, and I'm really excited to share this with you. So everything I present to you, it's not really my work, it's the work of the teams, and it's something we've been working on together. So I'm really, really excited to share the big achievements. I will say before I start, sorry, I've got a bit of a cold at the moment, so I hope it doesn't affect the presentation too much and I'm not sneezing and so forth. If people have general questions about the context in Afghanistan, I know you've had some recent presentations from other international mobile staff, but if people have some general questions, then I'm happy to answer them at the end. So to give you an overview of the MSF project in Afghanistan, we have many. So I'll start in the south of Afghanistan with OCA. We have this big boost hospital that you can see on the screen, which is primarily mother and child care. So we help women's health in the emergency room, but also neonate department, pediatrics, and it's got an ITFC sort of sophisticated therapeutic feeding program as well. And then also Kandahar is a multi-drug resistant TB project, but it also has nutritional, both inpatient and outpatient services now as well. And then OCB has many projects. So they have Kunduz Trauma Center that I'm sure you've heard of in the north. And then they have HOST, which is a project for obstetric complications, so primarily complex deliveries. And then it was OCB who were really taking the lead with the emergency earthquake response in Kunar recently. And off the back of that, they decided to stay in the region and do some assessments now to establish a third project in Kunar province in the east. And then OCP is in the west, so they support Herat Regional Hospital in the pediatric department, and also with a infant therapeutic feeding program, so nutritional center. And then they also have Bamyan, which is a primary healthcare project, which is the lower picture on the right-hand side. And this is supporting really remote rural sub-centers, so small primary healthcare clinics in a very, very mountainous area. And they're supporting them with nurses and midwives. And then Uqba in the northwest of Afghanistan, they support a big regional project in Mazar-e-Sharif in the pediatric department. And that was the only project. Uqba, I wasn't supporting. Don't ask me why. But I was busy enough, so I didn't complain. I will say that, historically, MSF has always typically been in these big hospitals in Afghanistan, largely because the history of war and conflict. They've always been involved in sort of surgery and advanced complex care. But for many reasons, this is slowly changing. We're still in these big hospitals, but we're increasingly thinking about more outreach programs. Why? For many reasons. Because of improved security in Afghanistan, there's more opportunities to go further to the villages now in remote rural contexts. But there's also more concerns about access to care for women, and we really feel we just need to get closer to these villages to really understand and bring healthcare to the villages, but also because of the changing funding landscape in Afghanistan. I mean, we've had the US funding cuts, which has really impacted primary healthcare, but also so much of Afghanistan is not being supported anymore by the same international, multinational organizations. So we really see primary healthcare falling apart, basically. So watch this space and you might see a few changes in the years to come. So yes, like I say, the top picture here is Boost Hospital. These are the typical sort of MSF projects in Afghanistan. But then the bottom picture is Bamyan, and this is a really remote, rural, mountainous outreach project. So gradually we're seeing a little bit more of this. So What do health promoters do in a hospital setting? Sometimes it can be a little bit confusing to think about where health promotion fits into all of our clinical work. Well, we primarily contribute to the medical strategy in both treatment adherence and prevention. So what does that look like? So imagine a big maternity ward. A mother is delivering her child, and the health promoter is there by her bed, and supporting her with breastfeeding, explaining the importance of exclusive breastfeeding, supporting with kangaroo mother care, but also explaining the importance of hygiene post-delivery, but also hygiene for the newborn baby, and then of course promoting postnatal care consultations and vaccination for the newborn child. But we're also thinking about prevention as well. I mean, in Afghanistan, we have these significant obstetric complications such as preeclampsia, eclampsia, antepartum hemorrhage. This all contributes to maternal mortality. So as a health promoter, we'd be thinking about how we can prevent this through promoting antenatal care, through more checkups, through safe delivery, through birth spacing and family planning, and also more timely reaction and response to danger signs in pregnancy. And to give you another example, if we take a nutritional ward, the health promoters would be there helping to orientate the mothers to the nutritional facility in these inpatient departments for nutrition. Mothers would be there with their children for 2 weeks, sometimes more. So we'd help to orientate them to the space. We would explain the importance of the therapeutic milks, the plumpy nut, and so forth. Would be supporting with breastfeeding support groups, doing one-to-one counselling for breastfeeding. But then in terms of prevention of nutrition, it gets a little bit broader. To give you an example, in our nutritional unit in Helmand, actually from all of our malnourished children in the ward, only 3% of these children were fully vaccinated. And only 10% of these malnourished children had been breastfed as a child. And the link there is, of course, if you're not vaccinated, you can get sick very easily, you lose a lot of weight and you become malnourished. And if you're not being breastfed as a child, then again, you don't have that natural immunity and you get sick very easily and you become malnourished. So boosting vaccination rates, boosting breastfeeding practices is really, really integral to preventing malnourishment. So I want to also stress that health promoters in these settings are such an integral part of our medical team. In Kandahar, the health promoters are actually there on the ward round, with the nurses and doctors to really make sure that they can understand that the specific unique circumstance of each patient and provide tailored health education. But also in this context, health promoters have a vital role in LAMA counselling. So this is families who want to take their patient away before the treatment is over. So we say LAMA, leaving against medical advice. And so what would happen is if families express that they want to take the child out of hospital before the treatment is over, we would do some family counselling with them, and we'd explain the importance of staying in the treatment, and we'd explain the risks of going home early. And when the health promotion team are involved, our success rate is 50%. So 50% of those families will decide to keep their child in treatment. So it's really, really important, and they really are, but they do some really, really fantastic work. So as I've already alluded to, health promotion is a lifeline in Afghanistan, and I'm going to give you a few examples of why I just felt it was so impactful. Our hospitals are serving communities from a very, very large catchment area. They're serving several districts, and we'd have women arrive with their severely sick children from very, very remote rural villages. And often when we would share health information with them, they would really express that they'd never heard this information before, but also that they didn't really have any other channels of information. These are quite often conservative families who they don't have social media, they don't have access to the internet. They were likely to have been in Taliban-controlled areas for decades, and they just didn't have the same exposure to NGOs and health information. So really felt that they were just so thankful and so thankful to be receiving this information, and it really made such a huge impact to their life. So this is just one quick example. one woman saying, "My child was born prematurely. I wish I had known about this information about skin to skin earlier so that I could have used this method with my child." So people often expressing that they'd received really, really important, significant information much later than they would have liked. But also we saw that these women often they were mothers at a young age. And they're living with their husband's family, and so they didn't always receive all of the support. They were often quite intimidated entering into this new household, and we'd see them arrive to the hospital quite unconfident, nervous, very, very shy, and I was quite interested by this. They were spending maybe 2 or 3 weeks in our facility, and I was interested in the impact that this experience was having on them, and this experience and how this was impacting their motherhood. So I asked this woman, and I said, she was leaving our facility in Kandahar after 3 weeks, and I asked her, what has this experience meant to you, being in a MSF facility for 3 weeks? And she said, being here on this ward has been life-changing. It feels like my mother's living room. Everyone is so supportive. Before coming here, I was so anxious and worried the whole time. I didn't know how to take care of my child, but now I am more confident as a mother. The health promoters show me how to breastfeed my him and what to do when my child is sick. Now I have no doubts. So you can see really in the course of 2 or 3 weeks, with all of that support, all of that education, constantly being able to ask questions and receive advice and really, really trust in that information, it just had such a big impact on many of these women. But also, I'm going to take you to Helmand. I want you to imagine a hospital facility, mothers there with their newborn babies in incubators. You can imagine it's terribly scary. It's intimidating, it's daunting, and their babies are premature or they're low birth weight babies, so they're very, very small. And often the mothers blame themselves. They blame themselves for something that happened during the pregnancy, and they think, why isn't my child healthy? And so that relationship between mother and child can be quite difficult. But the health promoters are there gathering the mothers up, baby in arm, and really helping to nurture that bond between mother and child. So they'd be doing kangaroo mother care and breastfeeding support, and I will walk in, and these women are laughing, chatting, smiling, and it's really, really, really powerful to see. So it was just incredible to watch, and I will tell you one story. I asked one of the female health promoters, I said, how is work right now? How is work? And I was really expecting her to say, oh gosh, Lizzie, we're overwhelmed, we're tired, gosh, this is really, really tough. But she said, work is amazing. It's amazing. Can you see the smile on my face? And the women, they're so happy that we can spend time with them and support them throughout this journey. So I really, really want to express just how impactful the work of the health promoters was, and the impact it was having on the lives of these women who would otherwise, feel often quite alone and scared about how to bring up children in their husband's household. So lastly, I want to share with you exactly, we're doing all of our health promotion through participatory techniques, so that we're having conversations, and it aims to just be like an informal conversation, basically, where we get people laughing and chatting and sharing their opinions and experiences. We might start with some icebreakers or some energizers, and we really, really encourage people to just share as much as they can. It's not that we're lecturing them and they just sit there quietly. So the aim is to really build their confidence and to really empower them. And so often when I would be doing a training, I'd ask the team to imagine a journey. Imagine a journey of a woman who arrives to our facility. She's incredibly nervous, she's unconfident, but within a few days, she gains her confidence more. And now she's acquiring more information, and she really, really understands very well. So what would happen is as the more the women would stay in the facility, you know, sometimes they'd stay for 2 weeks, 3 weeks, in some cases they'd stay a lot longer. And the longer they stayed in the facility, the more they had to teach, you know, we'd get them to teach the other women on the ward. And so, yeah, they went from a position of just listening to a position of teaching. So if they'd been there for 4 days, we'd say, look, come on, share what you know, what you remember from yesterday. And the aim is that by the time they leave and they're discharged, you know, they can go back and share this information with their communities and with the other women in that household and with their neighbours and so forth. So, yeah, some really, really fantastic stuff. You can see I get very, very passionate about health promotion and Afghanistan. So that was the aim. And then the other thing I was working on a lot was engaging the family. So engaging the family is always important, but particularly important in a context like Afghanistan. So as I've already alluded to, engaging the family was really, really important in terms of preventing barriers to treatment adherence. So we wanted to, you know, it might be that, you know, if the family was waiting outside and it had been 2 weeks and the treatment was still not over, they'd say, oh, come on, it's been 2 weeks. We want to take her home now. And so we really, really needed to engage the family, make sure they were on board and they understood the importance of the treatment so that we could make sure that the patient stayed in the facility. But also in a context where at the moment, women need to go to their healthcare centre with a mahram, a male caretaker, to access care. Again, we needed to get the family members on board. So if a woman said, you know, often a woman would say, well, I couldn't go to my antenatal care consultations because there was no one to take me or no one would agree to take me. So we really needed to engage the family to make sure they understood the importance of all of these hospital visits. But also, yeah, unfortunately, in so many cases, the woman is not the decision maker. In the case of vaccination for a child, it would often be the husband making the decision, or in the case of where to deliver the baby, often the mother-in-law is making the decision. So, you know, family planning, contraceptive services, again, it unlikely be the decision of the woman herself. So, you know, the woman would often say, you know, thank you for this information, this is great, but please share this with my family members, they will make the decision. So improving the life of the woman, it was so integral and important to engage the people around her who would be determining the circumstances for her. And yeah, to give you another example of this, you know, imagine we're promoting breastfeeding, and yes, it's about the mother and child, but you know, when she gets home, she needs to be encouraged by her family to breastfeed. They need to provide a quiet space for her to breastfeed. They need to emotionally support her in breastfeeding. So it really, we tried to stress the role of the family in supporting the woman and not making sure that all the responsibility was on her as well. But also, you know, she needs to have enough food and nutritional food to be able to breastfeed her baby well. And who's buying the food? Well, often the husband. And who's cooking the food? Often the mother-in-law. So we really stress the importance of each of the family playing a part. Yes, so what are we doing? What changes have we made, and how are we focusing on this approach? Well, we're actually, as much as possible, trying to have specific rooms and spaces where we can engage the family. So having to look around the hospitals to say, you know, where is our room where we can have to counsel families, to make sure that there is a quiet, confidential space to engage and counsel each family. So securing like physical resources, but in many of our projects, we've managed to have more staff to really focus on the family for this upcoming year. But actually, it's also really important to think about basic sleeping arrangements for the family. And to give you an example why, in Afghanistan, if a woman is having a C-section or if you have a surgical procedure, you need the consent of the man in the family before you proceed. So if that man is the other side of the city with his phone turned off, well, that's going to delay the surgical procedure. So it's in our vested interest to have that family close by providing some really basic sleeping arrangements so that they can be close by. And if we need to have that C-section or that surgery, we can contact them very quickly. So These are some of my key advocacy points. But generally, we're just trying to reach as many family members as possible through really innovative approaches. You know, we're also encouraging the watchmen and the security guards to do some promotion for us. Often when we meet with the men, we say, oh, actually, can you find 3 other men to come to our next session? So we're trying to reach as many people as possible, and we're really making significant progress. But I really want to stress throughout all of this, it's really patient-led, it's led by the women, and they determine the conditions in which we talk to their families. So all of these ideas have really come from them, basically. Often I just sit down with the woman and I say, look, you know, what's important to you? And they say, you know, this information is great, but please talk to my husband, or please talk to my mother-in-law. Because often the advice we give and the advice given by the mother-in-law is different information. And these young women often don't have the confidence to challenge their mother-in-laws. So they really need our support. And often I ask, you know, should we talk to your mother-in-law separately, or do you want to be in the conversation? And almost always they say, I want to be there present when you talk to my family. And this is because they sort of laugh about it, and they say, you know, if I'm there watching and listening when you chat to my family, you know, they can't pretend that they haven't heard. So it's a sense of accountability that we all listen to the nurse, we all listen to the health promoter, and this is what they said. So no one can deny that they didn't hear. So it's really patient-led. And just to give you an example of Herat project, so they have family visiting hours. So about 2 o'clock, the families come in bedside and they sit with their patients. And before that happens, we speak to the women and we say, look, you know, is your family coming in today? Is there anything you would like us to talk to your family about? And often they say, oh, yes, please, you know, please chat to them about the importance of good nutrition for breastfeeding. You know, I don't get enough food, or please chat to them about family planning. I'm desperate to have contraceptives. So we really decide with them, you know, what it is that they want us to chat to their family about. So it's you know, it's going really well. And it's also really important that we recognise that, yes, they are mother-in-laws and fathers, but they also have a social role as well. You know, mother-in-laws are really traditional birth attendants because they only actually bring their daughter-in-laws to hospital when something really goes wrong. Other than that, they'd be delivering the babies at home. So the mother-in-laws are a lot of the time traditional birth attendants, and in a number of cases, you know, often the men are also community leaders and religious leaders, so they also have a social role as well. What's next? Yeah, so I talked a lot about engaging the patients and the family members, but we do in Afghanistan, we're trying as much as possible to engage the wider community. And this is important for trust and building relationships and access to the communities, but also amplifying our health promotion messages. As I've alluded to, the work we do in health promotion in Afghanistan is so impactful, but I often just feel we need to do it on scale. We need to amplify everything. And engaging community leaders who are representatives of their community helps us to amplify that message. So, for example, there's a community leader for each community, and so in a community leader meeting, we might have a meeting with 20 community leaders, or we meet with a woman, and we meet with health shura, which are like health councils, or we have meetings with women leaders. So we have representatives of each community. And this helps us to amplify our message through sharing the message with them, and they go back to their community and share the message in the community meetings or in the mosque. And just to share one example of just, you know, how important this is in Helmand, they had a meeting about promoting antenatal care. And the community leader at the end said, oh, you know, thank you so much for this information. Actually, we didn't realise that a woman needed 5 antenatal care consultations during pregnancy. We thought they'll only go for antenatal care consultations if they have a problem during pregnancy. So what I'm trying to stress here is the knowledge gaps are still huge in Afghanistan. And I think that was the most shocking thing for me, just realising how much work needs to be done. And I will say one of the reasons for this is in the context of the war in Afghanistan, patients were coming from a much closer area. But now, because of better security, they're coming from a really, really far distance, and they're coming from a huge range of districts and provinces. So we're really seeing people that we haven't seen before. And this is why, we're suddenly exposed to people who really haven't had a lot of this information up until now. So the impact we're having is huge. But we're also working increasingly with Ministry of Health community health workers. So similarly, you tend to have 2 community health workers for each village. So we're now training and building the capacity of Ministry of Health community health workers so that they can go back to their communities and share their messages with their villagers. And in general, exactly, working with our stakeholders and community focal points is so important, because often in Afghanistan, we see contradictory information. We see us giving information. We see, religious leaders giving information. Often, there's a bit of a clash a lot of the time. So it's really important that we have one consistent message. And just this picture on the bottom left, we did a beautiful workshop in Khas this year, or last year, in 2025, where we asked the community focal points to really describe the health challenges in their community, and they did some beautiful social maps and illustrated some of the health challenges. So really, really excited about some of the things that are happening at the moment. How am I doing for time?
Half an hour left, but if you want questions, then 15 minutes.
Yeah, okay, I'm probably talking too quickly. Yeah. So, yes, I'm going to talk a little bit about the earthquake response. So this happened beginning of September. This is the first earthquake. The first earthquake, beginning of September, in Kunar province, which is east of Afghanistan. And it really affected a very, very remote rural population, a very mountainous village. And I mean, what was so beautiful about that response was just how quickly so much of the MSF staff were mobilized from different areas of the country, who left their projects, who left their families, who were so desperate to support. And everyone was so keen to really, really support in the response to help these people affected by the earthquake. And so this village population was moved from this mountainous village to the lowlands, to the town on this flat area, and this was the camp. I mean, there were a few camps, but MSF was working in one of the larger camps. It was called Patang Camp, and MSF set up a clinic just by the side. So the camp looked like this, and you can imagine MSF's clinic by the side of this. And I think at this stage you go, job done, great, access to healthcare, perfect. It was about 50 meters, 100 meters away from the tent. So you think, great, that's awesome. We can take a sigh of relief, job done. And I arrived sort of 6 weeks in, so after the acute phase, and I'm just going to focus a little bit on what I was focusing on. And actually, the situation and the context is a lot more complex than that. It wasn't really just about physical access to healthcare. We identified as a team that there were many other barriers to healthcare. Actually at that point we saw that the numbers of antenatal care consultations, or the number of postnatal care consultations, wasn't as high as we expected for that population size. And what I wanted to share with you is just the reality of some of this, and the reality is that a rural, remote population who have barely seen healthcare and have always been neglected by the healthcare context in Afghanistan, it's quite difficult for them to just start using a clinic, from night to day, because it wasn't normal for them to have antenatal care, and it wasn't normal for them to have postnatal care. So as one woman described, she said, actually, it's just our culture to do things at home. It's our culture to do things in the villages, and we don't tend to use, all of these high-tech sort of advanced consultations and so forth. So we were having these conversations with the community about, well, now the clinic is here. You haven't had it in the past, but this is your opportunity now to really, really make the most of having fantastic quality healthcare, MSF healthcare, very, very close to you. So it took a lot of work working with our health promoters to encourage the community to utilize the services, and we really had a fantastic impact. And I really want to stress here that behavior doesn't change overnight, and so it really does take some time, but I would say that we made a very quick impact in a short space of time, and I really feel that was because of the trust we formed with the population, and that was done through different ways. Actually, in this province, MSF has never worked there, so MSF was completely new to them, and we formed trust in different ways. Firstly, we had these beautiful meetings with the women's leaders and the community leaders every week, where they could really express themselves and really say what was on their mind and express their challenges. But also we did some really fantastic games and activities with the kids, and like hygiene and educational games to just get the kids moving around and having fun. But also when it came to health promotion, we really had a tailored approach for each family. Again, we were so close to them. The camp was a manageable size, and if we knew a woman was pregnant, we would go to her tent and we would really work with the family on planning her delivery and following up when the baby was born. So there were many ways in which we formed trust, and we really encouraged the community to make the most of this opportunity of having fantastic access to healthcare. But I'm going to leave it there, and it was just a short takeaway from the earthquake response, and something in particular I was focusing on. But Julia, who's the health promotion manager, who was also there for a couple of months, she's just returning, so I really encourage you to follow up with her if you want to hear more. So these are a couple of pictures from the kids sessions we were doing, which were really lovely. Okay, so lots of fantastic things to get excited about in Afghanistan next year for health promotion, but I'm just going to give you a couple of things that I wanted to share with you. So, funding's always tight, so I'm really excited to say that health promotion is expanding, and even if we get an extra member of staff or we get a bit of extra budget, we are so thankful for that. So thank you to everyone here who works in fundraising. But something I wanted to share is what we're doing with Kunduz Trauma Centre. So in Kunduz Trauma Centre, 63% of our burn patients are under 12 years old. So that's staggering. It's really affecting young children. But also from all of our road traffic accidents, 30% are under 12 years old, and 50% are under 18 years old. So we're really seeing that these injuries are affecting a younger demographic. So really shocking. And we wanted to do something within health promotion. We wanted to work on preventing this. And we spent a long time working with the families and the patients and discussing whether or not they felt some of these incidents could have been prevented. And I was actually quite surprised with how many of these incidents they felt could be prevented quite easily. Of course, there's a lot to be done in Afghanistan on a policy level, on regulation, but there are some instances that for sure could be prevented. So often it's unsafe use of matchsticks that create burns. There's touching exposed electrical wires and so forth, and then there's exploding cooking pots, or children playing in close proximity to burning water and so forth. So and children playing on the side of the road, that unfortunately leads to a lot of incidents. So there's a lot of work we need to do with stakeholders, government stakeholders. There's work we could do with families, but actually as a project, it felt like there was a lot of work we could do with children, but also both for their own prevention, but also their children tend to be caretakers of younger children, but also they will be the next generation of adults as well. So I'm really excited to be able to share with you that from this year, 2026, we're going to start an education program in primary schools in Kunduz. And this is really well received. So yeah, very exciting. And towards the end of 2025, we started working with some fantastic Afghan graphic designers to start illustrating some of these problems, but also some solutions as well. And it's always quite difficult to imagine, you know, households in Afghanistan. And so I don't know if you might find some of these images quite useful, because that's what was the best thing about working with Afghan graphic designers. They just knew the context and the settings so well. And the team designed this so beautifully. So just my last little story is how we're going to use these images for discussions about vaccination. So Afghanistan, you know, I'm sure you know, it's a context with a lot of measles outbreaks. Unfortunately, there is a high rate of vaccination hesitancy. And in the sort of weeks following these measles outbreak, I would spend a fair amount of time talking to the mothers and the families affected by measles, with their patients very, very sick in the measles ward. And I would speak to the families and ask them what were the barriers preventing them from getting their children vaccinated. And it was quite common for some of the women to say, oh, well, you know, I was impacted by the gossip. You know, we were having tea in the village with the other women, and they kept sharing stories and sharing these rumors and gossip. And on the back of those conversations, I decided not to vaccinate my child. So this image is to illustrate some of the community gossip and really to encourage that families make their own individual independent decision about vaccinating their child. And afterwards, this woman said, oh, I really wish I had not been influenced by the gossip. I really wish I had not listened. So we're trying to, you know, I don't think we're going to prevent the measles outbreak through pictures, but we are going to stimulate discussion. And most importantly, when we create images, is about people seeing themselves in the image. You know, it's about relatability. It's about relatable images. And this was another typical knowledge gap we identified. So when I was in Herat, again, I was talking to mothers and I said, oh, are your children vaccinated? And they said, yes, yes, yes. And then we'd dig a little bit and we'd ask, you know, explain the vaccinations to us. And they would say, oh, well, our children got vaccinated at the home and it was the drops. It was the drops. And so unfortunately in Afghanistan, there is a big misperception that the drops are all of the vaccines, but actually drops are really just polio drops. And this is somewhat linked to the polio campaigns in Afghanistan, and there's a confusion. So as a result, a lot of the families would think that their child is fully vaccinated, but actually they were not fully vaccinated. They had just been vaccinated with polio drops, often multiple times, which meant that they were exposed to measles. And so through this image, we're encouraging the families to think about where they need to be vaccinated. So in the bubbles, you can see children being vaccinated in the mosque, in the clinic, or at the home, to think about, okay, well, where do I need to take my child for vaccine? So just a couple of images, and this one is about dreaming for the future. What do I want my child to do or be? What do I want them to grow up as? And to really have those aspirations. And for vaccination week, actually, we had this beautiful board in Khost where we would have this discussion with families about, you know, what do you envisage for your child, to really see the connection between vaccination and having a safe and healthy child. So yeah, that's pretty much it. That is the presentation, and then I've got a little slide on the context in Afghanistan if you want me to share a little bit more on that. Otherwise, we just have general questions, I think.
Thank you so much.
I'm going to stop sharing the slides and then we can open up to questions if that's okay. Yeah? Okay. Any questions in the room? I don't know who's go first.
That's great. That's
I wrote down 2 questions. Thank you so much. That was the enthusiasm is glowing. Yeah, it was amazing. 2 questions. You talked about in terms of the preventative measures of promoting checkups and stuff.
Yeah.
I wonder if is there any way you've measured the success of that? Because obviously there are those barriers of actually people coming back, and they will maybe still be there. Yes, they now have the knowledge, but do they come for more checkups? If you understand the question.
Yeah, it's a really good a question. It's a really good question about monitoring our impact, and you know that's sort of my role to monitor our impact. And this is, I'd love to have as many success stories as possible, so I can go to the Medco and say, look, give us more resources, give us more funding. So I'm always trying to be quite creative about how we monitor our health promotion. This is why testimonies are quite important, but it's quite difficult because if we see an increase in contraceptive services, or we see an increased uptake in antenatal care, like you say, maybe it increases by an extra 100%.
Yeah.
I mean, I'd like to say that's all because of the health promoters, but you know, so maybe there's can be some other factors in play. So it's a little bit tricky to monitor. But yeah, you know, there is more we can do. We could say, oh, you came for this antenatal care consultation. Why did you come? Or, you know, who told you to come? And they might say, oh, the health promoters told us to come. So we do need to sort of implement more sophisticated monitoring techniques.
That makes sense.
Yeah, thank you.
Sorry, Tani, one more. Which topics do you feel like have the most success, and which ones get the most kind of pushback from the families or the decision makers, so the mother-in-laws and the husbands? When you do that share finding question, that's a massive question. It's a big question. Yeah, but like, which trend do you see any trends in which ones are like, after a bit of talking, they're like, yeah, this makes sense, and which ones are the hardest to kind of?
I will say it's extremely well received. I think often we're so fearful of talking about birth spacing and family planning and contraceptives, but I always say if we're thinking about it, they're thinking about it, you know. Not only because the economic situation in Afghanistan is so difficult at the moment, and it's so difficult for them to have large families and to be able to support them through schooling and you know, fulfilling lives and so forth. So actually we're often fearful talking about contraceptives, but actually it goes down very, very well. It's really about the way you approach the topic. And a huge credit to the health promoters, but in general it's so well received because I mean men specifically, say mother-in-laws can be a bit more difficult, but men they don't have access to information about women. You know, it's really not in the schooling system, and it's not encouraged in society to talk about women, and it's really taboo to you know, to be discussing some of this stuff. So to have a space where we can discuss this and for them to ask questions is so important. And I will say, you know, I've talked about, you know, bad things that happen or you know, children without vaccines and things like that, but it's often not through malicious intent. It's most often through lack of information, and often they say afterwards, thank you so much for this information. And you know, it's also not always encouraged to give emotional support to your wife. And then once we say, you know, it's so important to emotionally support your wife throughout her pregnancy, this is going to improve the conditions for mother and child, they immediately stop, you know, so we really see quite a big impact. Yeah, I would say vaccination is a tricky one because we do a little bit of vaccines in the hospitals, but primarily it's other providers. And unfortunately, Afghanistan have a history of difficult vaccination incidents, and they often complain that it's not safely administered. And these are circumstances we can't control. So vaccination can be a little bit tricky, but we always, if they're not sure about the safety of the vaccines, that they can come to us and have them administered by us, because often they say that the vaccinators are not trained, and the vaccinators just get the position because of politics, or they're a friend of the government and so forth. So they really have this belief that a lot of vaccinators are not trained. And I don't really know if it's true or not, but there is a lot of fear. So that, yeah, vaccinations can be quite a tricky one. It's something we really need to work on, and also see how we can strengthen those conditions and environmental factors as well. But yeah, I would say topics around women's health are really, really well received. Yeah.
Stephen, is your hand up?
Very quick one-liner, and then the second question. First one, you mentioned improved security a few times. I'm quite new, so I'm still learning about all our projects.
So question on what you mean by there's improved security recently. And then the second one was about the recruitment of your like health promotion coordinators. Is it well received by families to have, you know, females come out and have these jobs and come in access villages that have been quite hard to reach and remote? Yeah, just a bit more about the recruitment and people that actually fulfill those roles and how received they are.
Yeah, amazing. I love those questions. Yes, so secure. Yes, because they had sort of so many decades of war in Afghanistan, where people couldn't move around, you know, because of that constant bombardment of explosions and so forth. And now we're in a situation where there's no active conflict, and Afghans describe it as safe. I mean, it's relatively safe.
I wouldn't say it's how we describe it.
Yeah. But for them,
using
exactly, them, you know, compared to bomb blasts and so forth, and having, you know, shrapnel fly down into the air and things like that, they would describe it as safe comparatively, which has given them more physical movement to access hospitals further away. But the price of security, they say, for the price of security, we are birds in a cage. And this is what so many staff say, unfortunately, which is, you know, they have this physical security in terms of there's no war and conflict anymore. But they, at the price of horrendous social oppression. So yeah, obviously, as you well know, lack of access to education, employment for women, and really curtailing of fun. You know, no music, no games in Afghanistan.
There's no speaking in public.
Yeah, so it's but yeah, music's a common one. I mean, you're also not allowed games, so a lot of the staff would say, oh, we were going off to a picnic, we had our Ludo board in the back of the car, and the Taliban just opened the trunk of the car and take all the games out. Just you're not really allowed to go to picnics with your family. You know, women can't go to the parks and so far. So everything which just sort of gave people a lot of enjoyment and fun has sort of been curtailed. So yes, I use that statement because it was often shared. The statement of we have security, but we feel like that's the cage.
Yeah, that's really clear.
And this second question, what I love about health promotion is you don't have to have a medical background. I mean, a lot of our health promoters would have a diploma in midwifery or nursing, and that is really, really helpful, but not all of them. And so, you know, I don't have a medical background. So you can just learn the health education, and what's fantastic about that is they really are experts now. You know, some of the health promoters in Afghanistan, they've been working with us for years and years and years. They are experts, but first and foremost, often they're just mothers and they share their own experience as mothers, which is so powerful. And I remember watching a health talk, and the woman in the ward saying, she said to the health promoter, "You can't be from here. Where are you from? You know, you must be from Kabul. You seem really educated." She said, "No, I'm from the village down the road," you know, and because she was giving all of this fantastic advice and health information, she sounded like she'd gone through university after university after university, but really she was just from the village down the road, and she'd learned so much. So that's what I love about health promotion. It's such an accessible career with MSF.
Okay, so we've got 3 more questions. Sorry to rush you, Lizzie, but then Alan, and then Maddie, and then Stephen.
So you just touched on the Taliban. I guess my question is, what are the consequences of the Taliban being in charge for what we actually currently deliver, if anything?
And how they impact our operations. Yeah. So I will say that, so exactly, I think where MSF are, I will say that it really shows our privilege as MSF. And I think this is first and foremost because of our values. So we have our financial independence, which means we're not funded by governments, we're not funded by the US government, which means because we are publicly funded and we're funded by general everyday donations that you know, we're less intimidating to the Taliban. You know, they know we're not trying to implement US foreign policy and so forth. So that is so important in Afghanistan. But also throughout decades of war and conflict, we were treating everyone. We were treating Taliban soldiers. We were treating people regardless of their political background. And that has helped to form so much trust. And so relative to other organisations, we are doing a lot better. I will say, for example, I was flying around Afghanistan. I had visas and access to all of these provinces, and I really didn't have any problems accessing different districts. And again, that is because of those privileges we have earned through that trust and because of that strength of relationship. And so where we are, other organisations don't have those privileges, and I really think other NGOs or other INGOs have a lot of constraints. You know, not long ago we heard about the UN, even the UN, of their female staff not being able to go to the office. The UN were told by the Taliban that all of the female staff had to work from home. And MSF, we are so lucky to not only have female healthcare workers, because in general female healthcare workers can continue, but actually we're allowed female office staff as well. So we do have women working in finance or working as logisticians or working in human resources and things like that. So we are quite exceptional, and this is also administrative quirk that we are registered as an international organisation and not an NGO, and so we have some leniencies. But lastly, I would say, again, because of that strength of relationship that we are really trying hard to protect, and through all the fantastic work of project coordinators and head of missions and so forth, the Taliban can't just walk into our facilities. Even if they sort of approach the outside of the facility, they'd be stopped by the watchman, and we'd prevent them from just entering in. So this means it really is a safe space for our staff. I also don't like showing a lot of the images from the wards, because often when we do take photos, it's with the burqa down, but actually that's not what it's like at all. You know, it's a safe space for women. No one is wearing the burqa on the ward. They are just wearing a light headscarf, and it's often falling down their head and so forth, because it's a female only space. So most of our hospitals are sort of female only spaces, and it's really a sanctuary for both patients and staff. And yeah, so the security can't just come on in. And for example, in a Ministry of Health hospital, the Taliban would be going in and putting posters up and sort of religious messages and things like that, but they can't do that in our hospital. So I always say we operate in this sort of bubble, this fantastic bubble that we've created, where everything functions and our staff are paid on time, and our staff are paid on time, and we have electricity on, and we have a great supply of medications. And but down the road in a Ministry of Health healthcare facility, it would be very different. And
Sustainable relationship.
Is it
Are relationships sustainable, or do you feel like that's challenged sometimes?
definitely we have to keep working to maintain this for sure.
Yeah.
For sure, definitely. And there's a lot of work that goes into that. And I really don't want to, like I say, comparatively, I really feel like we have these privileges, and I do, like, you know, like I say, our wards are really a beautiful environment, and they are such a safe space. But this is within a context of our healthcare staff feeling like, oh, I want to do this diploma, but I can't, or, you know, I didn't manage to finish my degree and I can't, or all of our staff's mental health is so impacted by the fact that children go to school. It's not, you know, on a daily basis, I'd have staff come up to me and say, oh, I'm just torn to pieces that I can't send to school, and I don't know what to say to them, and they're sitting at home and they're so unstimulated. So I think the working environment provides fantastic distraction, but it's always there, and it's impacting everyone because they feel like they're in limbo, but also there's this pressure to leave the country because, you know, you don't want to live in a society where your children can't be educated. So MSF is one of the positive sparks coming from the context, but it's in a context of a growing dim reality, unfortunately.
I'm so sorry to interrupt. We've got about 3 minutes left, and I want to get round to everyone, Maddie, Stephen and Anthony. Can you give us rapid questions? So go. Like, are you sure?
I just wondered if the US military's Hot Mine campaign that they did, which also included giving out healthcare information about the Taliban, whether there's still a mistrust legacy around medical aid and whether that comes into kind of vaccination as well, like vaccinating children. That's where the Taliban is.
Yeah, no, I think it's a really, really good question. It varies a lot, you know, exactly. So much of vaccination hesitancy in Afghanistan is, like you say, linked to this idea that vaccines are part of US foreign policy. You know, this all stemmed from the assassination of Osama bin Laden, who was somewhat assassinated through a false vaccination campaign. And so now there is this thinking that, well, it's not a vaccine for moral intent, it's a vaccine because they want to exterminate the Muslim race. So yeah, it really, really impacted public health and vaccination coverage in both Pakistan and Afghanistan. So yeah, there are some communities who exactly are against foreigners or a little bit skeptical for sure. Really depends on the community, but then there are others who, you know, if we often interview our patients and say, oh, why did you come to us? And but you know, the strongest reason often is because it's well resourced and because you have international staff. So it really depends. I think each community was impacted differently from the war, and like you say, were they in Taliban controlled areas, were they in US controlled areas, were they part of the sort of the Afghan government, you know, were they in the communities controlled by the Afghan government who was supported by the US? So it can change village to village. I mean, Afghanistan is a context where people say between brothers, they were split. You know, one brother could have been with the Taliban and the other brother could have been with the Afghan government. So within the context of 5 kilometers, perspectives can change. So there really is not one answer to that. It can change quite rapidly. But what I will say is there was quite a lot of hope towards this new government in 2021. I think people were quite forthcoming about the idea of sovereignty, and people really held on to the hope that access to education for women would come into place. And, you know, the Taliban always said, we are creating education for women, we are going to implement it. But actually it's been 5 years and nothing's happened. So that hope is running out. And now that hope is dying. People are in limbo, and a lot of the trust and support that the Taliban had is actually falling apart, actually, because they're not seeing those results. Because most people, even if they are Taliban supporters, they want their daughters to be educated. Yeah, really, really do want their daughters to be educated, and also to some extent want their women to work because they need the income as well. It's really, really just having a really dramatic impact on the socioeconomic status of the family. So yeah, but hope is dying. It's not getting better. It's getting worse because they're waiting for this education to be implemented, but it's not being implemented.
Anthony, do you want to go super quickly?
Lizzie and I've got a bit of actually comms debrief after, so maybe if you want to go.
I was quite struck by the facts and statistics you presented on injuries related to accidents. I was wondering if you could explain what strategies you take to try and mitigate other health problems.
So exactly, because in our trauma hospital, and this was set up in the war to support victims of war, essentially. So it was previously bomb blasts, it was gunshot wounds and so forth. So there was never really a prevention strategy because we can't really get involved in that. But now we're seeing it change, and we need to more systematically collect data so we can understand the causes of this trauma it burns, and that's what we're doing in this really big push now to see actually 50% of the trauma is road traffic accidents, but yeah, a lot of household burns. You know, like I say, cooking pots exploding. Often it was, you know, a metal flask where you might put hot water in, and they'd go to the farm and put hot water in. and it's not properly sealed, and then it just spills onto the children, unfortunately. And this is because of cheap goods that are flooding the market, you know, that wouldn't meet sort of basic standards, and also the economic circumstances in Afghanistan mean that people can't replace items so frequently. So often these cooking pots are quite old and worn, and they need to be replaced. So we're learning more. We're also engaging with the community leaders more, and I think this is what we really have a responsibility to do, to be sharing this and you know, what we see as the problem. We have the data to be sharing this with stakeholders, so they can start to think about the solutions. You know, if it's about road traffic accidents, you know, is it about putting speeding signs up, or fixing parts of the road, or you know, having more regulation on speeding restrictions and so forth. So I think there's stuff that the local council can be doing, but as we saw, there's stuff we could be doing with families. So, you know, after discussion with families, they often say straight away they're going to make changes, but we still need to create more avenues of getting awareness out there. So I think the school program will be a really, really positive step forward. You know, I'd like to see more, but actually it's going to, yeah.
I don't think so. We have to finish.
Yeah,
this,
okay.
Everyone have a bit more questions. Everyone online.
Thank you so much.
That's really great.